So let's go ahead and get started. Welcome, everyone, since we're about 5 minutes in, and hopefully we get um, people who trickle in today. And so welcome again. I'm Rachel Pets. I'm one of the co-chairs for the Peds SIG. We usually like to start out with some announcements for the group. And so one announcement that we wanted to keep on everyone's radar, we're really interested in getting feedback on different topics, any type of programming that we can do as a SIG. So we are going to be sending out a member survey here shortly, hopefully today, to those who have attended previously. So please, if you have ideas, certain topics that you'd like to see, this could be related to, of course, our monthly membership meetings, but we've done different types of webinars and other things for our members. So we're open to feedback and would love to hear from you. Also, we're open and excited if you have an idea of something that you would like to present on. So please feel free if you have an idea for yourself. We're seeking presenters. We're also seeking people for our membership corner or membership spotlight. And that is more of we really just want to get to know our members a little bit better and the great work that they're doing. This often comes up in the context of that this is how we do it. But for those who are less interested in, I want to do a full-blown 15-20 minute presentation, we'd love to hear the great work that people are doing in kind of brief 1 to 2 minute snippets. And so it's a great way for us to get to know those who are coming to the meeting. So please reach out to Courtney or myself if you have an interest in This Is How We Do It, or of course the membership spotlight, and look out for that survey that will be coming out soon. Other updates, we do have a call for proposals are still out for the CFHA conference, so keep that in mind. They're open until the 15th of March. If you have any job announcements, please feel free to put in the chat. We also put those into the our minutes that we send out to people. And our next meeting will be April 1st at 12 p.m. I think at this point we have Dr. Lamari-Fisher, who's going to be joining us today and doing a presentation on her work and pediatric cardiology. Prior to her giving her presentation, we'll have Jonathan Larson do a research corner. So it really kind of sets the foundation of our discussion and related to her presentation. So I think we'll segue over there.
All right. Hello, everyone. Nice to see you all. So today I prepared a presentation that should have some ties with what Dr. Lamari-Fisher will talk about today. Let me share my screen here. Bring this up. So this is an article that was published in 2015 on basically the family psychosocial risk screening guided by the Pediatrics Psychosocial Preventative Health Model, PPP-HM, and it introduces a validated or develops a psychosocial assessment tool. So here, the background, the psychosocial needs of families with children facing life-threatening pediatric illnesses are well documented. However, effectively identifying these needs and providing evidence-based care remains a challenge. Therefore, systematically screening for various family psychosocial risks can effectively identify treatment needs for patients and families. And here you have the Pediatric Psychosocial Preventative Health Model. And this is really a public health framework used to conceptualize families with varying levels of psychosocial risk, along with interventions matched to that risk. So the base here, we see at the base of the pyramid, you see the universal families. And these are families that are concerned or distressed about their child's health problems, but who are generally resilient and able to cope and adapt to their child's illness and treatment. So at this tier, you might provide psychoeducation and family-centered care. screen for indicators for high risk. Next, at this middle tier, we have targeted, and this is families with pre-existing concerns or difficulties that may contribute to continuing or escalating vulnerability during treatment. And at the top, we have the clinical treatment level or tier. And this is when there's one or more pre-existing chronic or complex problems resulting in the greatest need for prompt and often intensive intervention. This might look like consulting with a behavioral health specialist, intensifying psychosocial services, and addressing the impact of medical treatment. So this particular study looked at the psychosocial assessment tool, and this is a brief 5-10 minute parent report screener of psychosocial risk for use in pediatrics. Response format includes yes or no questions, Likert ratings, fill in the blank questions, check boxes. And the number of items is variable depending on the age of the child, siblings, and whether it was adapted for different diseases. It looks at demographics, diagnosis, family structure, family resources, social support, child knowledge of disease, school enrollment, school placement, child problems, internalizing, externalizing, social and cognitive, sibling problems, family problems, and stress responses. And the PAT has been used for families across a broad range from infants to adolescents. It's been translated and validated into many languages for use in the United States and internationally. And it can be administered via web-based or REDCap and also in paper and pencil format. As for the study, what they found is that it had a good internal consistency or reliability, had good retest reliability among mothers and fathers, and it was significantly correlated with other measures of acute stress and child behavior problems. I believe it was the BASC. And what's interesting too is this measure basically tied in well to the PPHM model. 15% of families across multiple sites. I believe it started at the Children's Hospital of Philadelphia, and then it went on to look at Australia, Canada, Netherlands, Mississippi, Georgia, primarily a cancer population. And to this day in 2018, it's still utilized, or as of 2018, I should say, it's been utilized in about 29% of cancer pediatric places. Here's some further data that we kind of just covered, but here's some kind of sample questions what those might look like. And so kind of this overall, we know that screening is the first step to assure that psychosocial risks and the resiliencies of families are detected early on in the course of care. And in this study showed that the PAT was found to be a brief and validated measure of psychosocial risk, and again, available in various formats and languages. And it was really cool how it corresponded to these tiers: universal, targeted, clinical treatment, which can then obviously provide direction for the delivery of evidence-based psychosocial care. And thank you.
Thank you so much. Well, I am so excited to introduce our guest speaker for the day, Dr. Lamari-Fisher, who is also a good friend and former classmate of mine from our graduate program at University of Texas at Austin. And she has continued to work there and do amazing work at Dell Medical Center. So I will let her share her screen and kind of share the topic for the day.
Thank you so much for the introductions. I'm feel very privileged to be here today. I love the CFHA. And I'm just very grateful that I'm here today. Okay, let me see if I can figure out the whole sharing situation. I'm a little bit older, so I don't do very well without my tech support. That's my children. They don't like it when I call them tech support. Okay, and okay, great. Let me see, what can you guys see? Can you just see my screen?
It looks, it's back but small, so not yet a presenter view.
Oh, okay. For some reason it's not duplicate slideshow. Nope. Exit. Sorry, I'm not I
think bottom right.
Okay, let's try again. I think it's a, hold on, let's try again this time around. Is that, oh, there we go. Well done. We did it. Okay, so thank you so much for having me. It's an honor being here. I think the CFHA does lovely work, and it's, I was very grateful to Dr. Valentine for reaching out. So I wanted to talk a little bit about optimizing outcomes for patients and families affected by CHD. I'm going to review a lot of the what we know about the population, and at the very end, it might feel short, but there's a short discussion on how we can partner between specialized care and primary care. And I'm really hoping it can open the door for more conversation of what that would look like. Okay, and here we go. Is it changing? There you go. Okay, so why would we have specialized healthcare within the congenital heart disease program? As you guys all know, only about 22% of medical outcomes are affected by genetics and biology. The remainder are psychosocial factors, individual behavior, social circumstances, access to healthcare, and so on. Within the CHD realm, there's many factors that confer developmental risk. We have structural metabolic abnormalities. So for example, we know that a child with DTGA transposition of the great arteries, they even when they're born full term, their brain is still similar to a healthy 35-weeker. So they're even born with a smaller brain, less mature. The timing, there's the iatrogenic factors, the timing of surgery, CBP, exposure, ECMO, CPR, interpersonal factors. Familial factors can affect functioning. So interpersonal factors, so the feeding is a big issue. I think I've seen this quite often. A lot of families feel like there's not much they can do for their child, and then the double whammy is now their child can't even eat. And that really seems to affect how they perceive themselves as a mother or as a father, or how they care for their children. And then, of course, there's some factors that we know affect outcomes. So parenting style, marital status, medically anxious parents, and so on. You know, regardless, though, while all of these neurological components, all of these components confer neurological risk, they don't necessarily completely account for neuropsychological differences. So what we know from the CHD psychosocial perspective, from the neuropsych functioning, we know that over 75% of children have are at risk or deficit in at least one neurological domain. About 75% of infants and toddlers have gross motor or fine motor delays, regardless of lesions. So we rank lesions in terms of severity. And regardless of the severity of the lesion, with an ASD being an atrial septal defect being one of the least severe or least risky lesions on one hand, and HLHS on the other, hypoplastic left heart syndrome, regardless, most of them are at risk for motor delays. As they grow and develop, you see a lot of neuropsychological differences in language, executive functioning, visual spatial processing, developing complex narratives. I've seen a lot of math and reading differences, and we'll talk about educational outcomes on the next slide. So, before I talked about executive functioning, and within the educational functioning, we do see a lot of ADHD type profiles. What I tell families is, do I know if your child would have had ADHD if they hadn't been affected by congenital heart disease? I don't, but this is what the behavior looks like, and we know how to treat it. So whether that would have been there or not, if the lesion wasn't there, is sort of irrelevant, but it helps families understand that whether it's due to CHD or not, we still sort of treat it the same. We want to make sure that we provide those types of interventions to support children. They're 1.25 more likely not to meet reading or math standards. 20% of students with more complex lesions repeat a grade. Even with milder lesions, they need some type of remedial support. When it comes to special ed, we see 50% more likely to enter special ed. They're more involved across all special ed categories. And as the severity increases, so does the likelihood of participation. And they're historically underserved in school systems. School systems just don't know how to treat children affected by congenital heart disease. And we don't expect them to. That's an unfair expectation. When it comes to psychosocial functioning, we do see an increase in sort of externalizing, internalizing behaviors, a kind of social challenges, psychosomatic symptoms. They just can't participate the way other children participate, which is difficult for the kids to understand. There's a decrease in quality of life, self-esteem, understandably physical functioning. And as they age, we have limited educational success and limited employability. A few facts to consider that I did not talk about. I think I forget sometimes that, I read it so much that I sometimes, and we talk about it so much within congenital heart disease that I sometimes don't think about that maybe others don't know, but 1 in 100 children are born with congenital heart disease. So it is the most frequent congenital diagnosis. It is associated with, sometimes is associated with different genetic abnormalities, but not necessarily associated with genetic abnormalities. And so, for example, children with trisomy 21 are more likely to have an AVSD, an atrial ventricular septal defect, which requires a surgical intervention. It's also about a quarter of that 1% have a pretty complex lesion that requires multiple surgical interventions over time. We are now at a phase in development of CHD that we have more adults with CHD than we have children being born with CHD. So I work with adults now who are the first generation to live this long with certain circulations. And we just didn't know when they were young what we know now. For example, I have a 42-year-old woman I've been working with that we finally got her diagnosed with autism. She didn't understand why she was the way she was. Then we had complex addiction issues, and eventually we reached the point we were able to appropriately diagnose, medicate, treat, and she's doing great. But it took a long time because we just didn't know back then what the problems were. So it's a complex diagnosis that is really affected by the low oxygenation in the brain. But that doesn't account for everything. After that, there's a lot of parenting components, medical components that affect functioning too. So I think I'm preaching to the choir here. I think we all know how caregivers affect functioning. So in the CHD field, we know that there's a reported levels of distress and hopelessness with caregivers who have children who have complex medical illnesses, and that it can interfere with the parent bond because we do see them a lot in infancy. So it can interfere with the parent bond, which then affects, I think it has a very strong effect over the lifetime, right? So then as a child, as a parent is not doing it well, it affects a children's cognitive health related and behavioral functioning. And from the trauma in the ICU research, we do know literature, we know that when a parent sees their child distressed, they become distressed. So we have this bidirectional relationship where they're sort of feeding each other's functioning. And as you guys know, so basically caregivers mediate outcome. And the good news is, and I think this is probably why you guys are all within the primary care field, because you probably really believe in it. I know that Dr. Valentine and I talked a lot about it. She was the one that really sort of helped me find words for this when we were still in grad school, is that resilience is not a stagnant state of being. Resilience can grow and develop over time in different phases, in different areas, right? So you could be resilient academically, but really struggle psychosocially, or vice versa. You could be doing well academically earlier and then struggle later on in life. And I think that's where we have the opportunity through early intervention to really promote and strengthen child's development over time, right? So I'm going to talk a little bit about how we do it here, because I think we do it really well, but I'm biased clearly. But I think there's a lot of programs across the country that offer psychosocial services. So I think knowing a little bit how different programs operate can really maybe help you guys support patients as they access services. So one of the things when our current surgical team came here, they decided, how are we going to make this a special place? What is going to be different? So we decided we were going to rethink the way CHD was approached. And we wanted to put the patient and family in the center of all the care delivery. So we wanted to think about every aspect of care. And one of the things that they came in and they were looking for a psychosocial team, which was not necessarily the case before with the other cardiac surgeons here, congenital heart surgeons here. So there are some assets and modifiable risk factors that we want to promote. So we know that promoting trust in physician, helping families adapt. I think the parental coping and attachment is critical in that early stage. I don't do as much work as I used to do in it, but I do think that that's one of the key roles we can play within the unit. And I think even after that, supporting families in their attachment. And then there's medical things that I think that can be done that clear. I should not be involved in the medical things, nor am I. But I do talk a lot to parents about feeding intolerance and failure to thrive, because that is a really stressful space for families. Being able to help families get out of the hospital quicker, helping pain management, it's all part of the process here. These are things that we can affect over time. As Dr. Lassen mentioned, he talked to you guys about the public health approach of pediatric psychology preventative healthcare model. And we took it because we started from the ground up as a psychosocial team, we took this approach and we decided we wanted to move away from the typical siloed approach of like, oh yeah, you got to go see social work and they'll refer you to psychology or some kind of weird gatekeeping. We decided we were going to take a horizontal approach and we were going to really try hard to have everybody work to the top of their license by doing it this way. You saw some of the numbers, about 50 to 66% are within the universal phase, just typical functioning. Here's where I started thinking, okay, well, who then would go? If somebody comes in and fills our measures and they're within this range, who will go see the patient? And, you know, psychology doesn't have to go. Like, you know, that's just taking a jackhammer to a nail. Like, I don't need to go. Like, it would be great to go because I like the families, but that's not the point, right? So they don't need that service. We have school advocates, educators, child life, social work. They can do the work just great without me. Then we start looking at that targeted phase. And this is where we start moving towards maybe more specific approaches. This is where social worker and we may overlap. A lot of conversations happen in those areas. And then that high-tiered approach, this is where I think you should have psychology, psychiatry, school advocates. I mean, this is just a very wraparound service intensely, but I think sometimes those are also the families that everybody jumps in and it gets really messy. So I like the idea of sort of separating services out and making sure the right people are doing the job. Otherwise, it's just too much. So how do you access services within us? Well, we have 4 social workers, 3 child life specialists, and a psychologist, and we are getting a postdoc this year. I'm very excited about that. And we've actually partnered with our neurosciences colleagues, and we've developed the cardiac neurodevelopmental follow-up clinic. And there's also the other thing that's pretty unique about this field is that a lot of so surgeons collect data constantly, and they have massive databases that they're always uploading data into. And about 10 years ago, maybe, the Cardiac Neurodevelopmental Outcomes Collaborative started that created a kind of a recommended guideline on neuropsych testing on the outpatient basis. So we're part of that, and we enter data into that, unidentified data into that. And that becomes relevant down the line when I talk a little bit about follow-up there. So this is how you access services. I know it looks like a lot, and yeah, it actually is really nice doing these flow charts because it makes you think about, well, how do we interact with people and what is our job at every time point? But we start at outpatient, we start from fetal at birth, we follow inpatient, and then we follow back outpatient again, accessing different people and services along the way. When we do see them outpatient, we give them a series of measures. So we give them the PAT, we give them the fetal PAT, and then for the patient, we give ages and stages. And then for parents, we give the DAS-21, which is a scale that was developed out in Australia, and it measures depression and anxiety and stress for parents. I like it because it's just a scale. It doesn't it's not necessarily exactly mapping. It's not a PHQ. It's not a GAD. I'm not trying to diagnose parents. I'm just trying to say like, hey, you're really stressed. What's going on? And in fact, 2 weeks ago, or maybe a month ago, I lose track of time here. A family was like, do you even read these? And I was like, actually, that's why I'm here, because I have read these and I'm really concerned about what's going on with you guys. And the mom was like, oh, well, it's actually all my medical stuff. And I was like, let's talk about that. How can we better support, right? So even when families just kind of get frustrated, then they see that we do, in fact, sort of are reading them and trying to be more mindful on how we best support families. So during fetal consults, we introduce the team, and I start discussing neurodevelopmental outcomes from fetal consult. And I know it feels intense, and I can see families, they're glazing over because they've gotten back-to-back bad news about their child. But here's what I tell them. I do not want you to be at 6 months of age, your child being, and then you suddenly being like, what do you mean there's neurodevelopmental outcomes? Why didn't you tell me this earlier? Like, I want you to hear it so many times that it's not shocking when the neurosciences nurse practitioner walks in. And then I want you to ask the physician good questions like, well, why do we want to do surgery now if it's going to affect their outcomes in the long term? I know why they want to, because you can't live without the surgery, but the family needs to hear that. It doesn't matter what I know. So that's why I really I talk about this at early in their process. And we do warm handoffs across the board. Every time we see someone in consult clinic, we do warm handoffs to the rest of the team. So in this case, we'll actually do a warm handoff to the psychosocial team and to our comprehensive fetal care center. So then we can cross-examine, just make sure that we all have all the data that we need to best support this family and make sure they have everything they need. Within the clinics, we do have social work and psychology front facing, so we don't have to have everybody there. It's really about building a team that sort of trusts we have each other's back. So, psychology, social work might do slightly different evaluations, but what we've done is talked a lot about how do we conduct a similar assessment but with data that's relevant to the rest of the team. So we'll ask about development, we'll ask about resources, we'll ask how they cope with medical care. And then that goes back to everybody else. It goes back to the rehab team, the inpatient rehab team. It goes back to the child life specialists. We ask information that we know affects care on the inpatient unit. So then actually when a patient is admitted, we email the attending team and we just say, hey, this family has 1 car and they have 3 more kids at home. If you need them to be here at a specific time, you need to tell them ahead of time so then they can be available to you. So please keep that in mind that they're low resourced. Don't expect them to just show up whenever you don't, at the drop of a hat. So it's really about thinking, what does the team need to be successful and what can we get ahead of time to help them be successful? So inpatient, it's child life and social work front facing, and they refer to me as needed. And we came up with this consult guidelines, but I really do not want us to give it to the team. And I know that sounds a little peculiar, but here's my thinking. I don't want the team to have to figure out who do I need to contact exactly. Is this child life or is this psychology? Is this social work? First of all, then if they pick psychology over someone else or whatever, then someone's feelings are going to get hurt. We don't have time for that. We're too busy. Secondly, I really believe we need to maintain our own voice in our care, like our own agency and autonomy on how we deliver psychosocial care. So we actually have a generic Volt group, or what I tell them is find any of us and talk to any of us, and then we will figure it out. So last week I got an email, I actually followed up, and then I emailed them back. Well, I was supposed to email them back this morning, but I'll email back this morning, say, hey, social work is already following this mom, so we're good. This kid, I saw them, we're in a good space. So thank you for telling us. But I immediately always respond with, let me check who's following this mom and make sure that we're, or this child, make sure we're all on the same page. So when it comes to neurodevelopmental services, we have lightning rounds twice a week and full developmental rounds once a week. And then Thursday, the attending and the neurosciences nurse practitioner meet by bedside with and go over medications and pending imaging and so on. So remember I talked about the CNOC a while back. So there was an article that came out in 2023 by Ortenow, and what they found is across the country, The average follow-up rate is 29% for neuroscience psychological follow-up. And it ranges between 8% to 54%. Last year, our follow-up rate was 70%. And I really think it's because we do this very, very strong, warm handoff, and we're constantly talking about development. So that's why I think it's important to hear it earlier. I don't want them to feel like another sucker punch has been, because they're already going to get a lot of difficult news along the way. So the more we can make them feel empowered and knowledgeable and engaged, the better for me. So I think that 70% is pretty great and a good indicator of the hard work that goes into connecting these families by the full developmental team. This is who we have identified for follow-up, and this is not just on our a whim. This was actually an article that was written in 2012, or published in 2012 by Marino et al., which was sort of seminal in the field. It identified risk criteria for developmental delays and disabilities, and these were the main criteria. So we use that. We also use that to determine who goes, and the first four are our primary. And as our neurosciences team evolved and developed and grew, we were able to send more people. But initially, we were sort of limited. But these are good things for even you guys to know that there's certain risk factors. So why is open heart surgery as a neonate important? Because cardiopulmonary bypass and sedation. So I think the FDA said that sedation under the age of 3 is not recommended because of the risks it confers. And we tell that to families. And then I also tell them, you need to speak to the surgeon why we do it. And the reason we do these surgeries is because the child cannot live without the surgery. So there is no scenario in which life and no developmental delay risk is available to them. So we have to balance the risk that is available for each family. And the surgeons are very, very thoughtful about that. Single ventricle diagnosis is actually when you literally have half a heart or a hypoplastic left heart, and the left heart is responsible to push blood throughout your system. So these are children that are chronically cyanotic. That means they have blue and red blood mixing. They have lower oxygenation in their system. They undergo multiple surgeries. Well, they have the main 3 surgeries, right? So they have the Norwood at age 7 days of life. And then we try to get them to the Glen by 4 or 5 months. And then they have their Fontan surgery later on, around 3 to 5. The Fontan surgery sort of bypasses the typical heart functioning structure. So typically, your blood pours into your heart and then it goes to your body. And this, with the Fontan, it goes straight into your lungs. The problem is now we know that there's Fontan-associated lesions in your kidney and kidney disease and liver disease. You may see patients with some kind of early cirrhosis in their liver as adults, but that's because of the pressure of the blood being pumped out. So that's why now there's actually adult congenital heart clinics that they follow patients because their anatomy is so unique and the issues associated with congenital heart disease are unique within themselves. So I always tell families, even for a fetal consult, your child will need follow-up for the rest of their life. And we highly recommend, if you can follow up with an adult congenital heart program, please do. Wherever you land in life, please try to keep an eye on that, because adult heart diseases tends to be acquired, and this is congenital. It's just very, very different. This is the follow-up that's recommended by CNOC and what we do as well. And then the cardiac neurodevelopmental team then sends back to us for therapeutic services. On my end, we do outpatient therapy, and then we have multiple specialty multidisciplinary clinics. We have ACHD, AOCA, that's anomalous aortic origin of the coronary artery, heart failure, heart transplant VAD, preventative cardiology. IMPACT is our program that follows children in between the Norwood and the Glen, because that phase is actually extremely critical. Babies tip really easily and get sick and can die very, very quickly, unfortunately. So they're followed very, very intensely. We also have a ICD program, but it's not a hospital program. I do get a lot of referrals from that program because I think those arrhythmias are very overstimulating for families and for patients. So within primary care, how can you guys support? I mean, I think what's a few things that would be great is asking them what they know, making sure that, you know, it's interesting that I know that they go to the pre-consults with the cardiologist, and then sometimes you ask families and they give you a very, very rudimentary understanding of their lesion. And that just tells you where people are, right? If they cannot tell you, that just tells you where they are. And that's an opportunity to sort of help ensure that they have appropriate information. Also asking them what's available through their cardiac center. Some of them have rehabilitation services, some have neurosciences or neuropsych testing, others don't, depending on the how big the center is. If you're in a more rural community, being able to connect them locally, they will need some kind of support, encouraging them to follow up. Assess family functioning. I think parents are so busy taking care of the children that sometimes siblings are forgotten, sometimes parents are forget themselves. I have a family I was trying to call this morning. I saw them in 2018, and they were prepped that I was going to call and gave permission for me to call because she said that the phone still, when she sees a Dell children's number, she has such a traumatic response to it, like it just overstimulates her. So I mean, it's that sort of, it has such a long effect on functioning. If you can offer ADHD and autism testing, please do. They don't look like your typical, sometimes children affected by congenital heart disease do not necessarily look like your typical children affected by autism or the meet criteria. They just look a little bit different sometimes. I can't describe it. It's just, there was a child I was working with. I was pretty sure he was on the spectrum. I didn't tell the neuropsychologist because I didn't want to affect her outcome. She diagnosed the same thing, but the teachers were like, no, he's fine. We don't see that because he doesn't have typical reactions, but he's very clearly, his behavior is very clearly spectrum-ish, especially within the context of CHD. So I don't know exactly how more to describe that, but you know, that just doesn't, maybe it's not as extreme in some cases, so people are easy to dismiss. I don't know, it's a very interesting conversation. So the parent training piece is pretty critical. I think, you know, we ask parents, I think this is a combination of, you know, maybe parenting choice, but also a iatrogenic component. We tell parents, I need you to micromanage your kid. I need you to watch them. I need you to take their temperature. They should not be dehydrated, especially as an infant, right? Or maybe they're in a gland phase and they're waiting for their fontan and their child is getting blue because they desaturate. And we're just like, yeah, just keep watching, just keep watching. And then they'll get their fontan or their gland. And then we're like, great, now you can just go ahead and parent. And parents are usually like, I just, you know, it's not a switch. I don't just turn it on and off. I'm not just going to suddenly let my kid cry their heart out now. They don't even know how to let their child cry it out. And they worry about their heart functioning, right? I was on the phone, I was doing a Zoom call the other day with a patient who actually got a heart transplant. And, you know, his mom is like, I don't, you know, what do? I just let him cry it out. I mean, he should, you know, I'm just like, yes, you can let him cry it out. Actually, his heart is good. It's not even, I mean, it's a new heart, but it's just such a, it's so beyond the scope of what they've been doing for 4 years, where they've been managing every single piece, that suddenly just to let go and parent typically is pretty complex. So a lot of it is centered on catching them being good, redirecting, giving appropriate consequences. Because I keep telling, what I've told them, a parent once said to me, you know, I'm not putting my child through all this pain to just leave them at home wrapped in bubble wrap. That's not fair. So I want them to do whatever they can do. And I sort of share that with families. I'm like, I mean, it's a lot to put your child through and your whole family through to then not let them do anything. Like just sit there, don't move, right? Like we're doing this to give them a full life. So then they can play softball or baseball, and they can, if they want to go have a sleepover, go to a sleepover. And if they, you know, I don't know, learn to drive, be annoying kids, whatever it is that they do, right? Like that's the whole point of this. And please advocating on the school level, because I think the schools just don't quite understand how it's also an invisible disease, right? Because they just don't look different half the time unless you can see the scar on their chest. People just don't know they have a congenital heart issue. So they don't know what that means. They don't know why they can't focus. They don't know why they're struggling with math. They don't know why they can't do PE. They're giving them a hard time. Sometimes PE coaches are like, just get out there and run. Some of these kids can't run. They don't have the lung capacity. Like it's just complicated. So even being able to sort of ask these questions and then helping them advocate. And then, of course, there's the cardiac medication. So, okay, sometimes we put them on diuretics, like a Lasix, and that's to help with squeeze. Being able to advocate for them to have access to the bathroom, because they need to. When you need to pee, you need to pee. When you're on a diuretic, you have to go pretty quickly, so they may come in and the parents telling you like, well, they're peeing on themselves all the time, and it may sound like enuresis, but if they're on a diuretic, so it's really about shaping the expectation of the parent to help them get to the restroom in time. Another thing is sometimes we put kids on warfarin or Coumadin, especially if they have a mechanical valve. That requires frequent pokes to check their INR level, because you don't want to over or undercoagulate, and you switch your dosage changes depending on that. And then within that, they have to have a consistent diet. So keeping that in mind, because if they have a specific diet and they start switching it up, their INR may be off. So it's a pretty complex diagnosis. And then the other part is, I thought this was quite interesting. I learned that a couple of years ago, but when a child is on beta blockers, specifically metoprolol, you can't put them on Prozac or paroxetine or bupropion on them, because there's a really significant serious adverse interaction between those. Some of them with you can maybe take escitalopram with metoprolol, but you can definitely take venlafaxine and sertraline on them. So definitely there's some medications. I just ask families to work with their cardiologist to determine what is a good medication to take. We do put children on stimulants. We just do it very carefully. So I have an adult, we partnered with Dell, and I have an adult psychiatrist that sees the adult congenital heart patients, the adults, and she works very closely with the two adult congenital heart cardiologists to make sure that we appropriately medicate within the spectrum of their kind of anatomy. And that's it. I spoke a lot. What questions can I answer?
Yeah, thank you so much. When we were talking about this, I really was trying to kind of think about, how does this translate into my behavioral health consultant role kind of in my primary care clinic, and what could I do to better understand and also help those families? And so I thought maybe we could talk a little bit about that piece, about how we connect with specialty back into our integrated settings. Does anyone have any thoughts or comments that they want to start with?
I think that's a good question. I think a big part is sort of asking to see what families know, or even I think the parenting piece is huge. So I touched a little bit about attachment. I don't do as much now, but before I really worked very closely with families, and I don't do it because of bandwidth issues when they're in the intensive care setting, because I think there's a trickle down effect. I think so. Your olfactory bulb is right next to your limbic system, right? And you have a very strong sense of smell. So in fact, we know that infants and neonates recognize their parents' smell. So I tell parents that, I'm like, they recognize your smell, they recognize your voice, and your touch is gentle touch. It doesn't matter how nice we're trying to be. Your touch is different to our touch. Please be by bedside if you can. Please find ways to soothe your child. Please watch your child's cues. There's things that we will miss, but you will not miss, because you're there by bedside. Help us see your child through your eyes. And I think For me, that's critical because then it gives them the confidence that they can be a good parent to a really complex child. And I think that pays dividends in the long term. So that I'm a big fan of the developmental program we've developed. Does anyone have any questions, thoughts, feelings, stories?
I had a follow-up. I was curious to hear more about the interventions that you provide to families, and you kind of talked about kind of the parent training, but I saw the list of kind of potential kind of presenting problems and things that you can help with. So maybe giving somewhat of an more of an example there. And I'm also wondering too with the caregivers, because you mentioned you also screen caregivers, and so what you do with follow-up with them.
So it varies. Thank you for asking that. So I feel I'm a little bit like you guys in that you don't know what's behind door number one when you go to work. So you're sort of just working with whatever's in front of you. And it's kind of the same for me. I feel like there's days I'm working with fetal patients in fetal life. There's sometimes I'm working with adults. There's parents. There's children. I mean, I feel like I'm working the gamut. I'm preparing for transplant, post-transplant. You name it, we do it here. So you know, there's the psychosocial illness model by Rollins, and what I love about that when I train is some of the students I train is I like thinking of illness. And it's not a stagnant thing. Like it could become incapacitating. It could be constant. It could be life-changing. So helping conceptualize what this illness looks like. So an AOCA diagnosis is actually a pretty hard diagnosis for families because it's something that we see more often now, but it's the second leading cause of death among young athletes. And usually it's diagnosed after a aborted cardiac death, sudden cardiac death, or a secondary to sudden cardiac arrest, and good CPR keeps the child alive, right? So suddenly somebody who's incredibly healthy is suddenly not healthy, or an arrhythmia is kind of similar. And now they end up with either, if it's an arrhythmia, they end up with a pacemaker or an ICD. With that, they might end up with surgery, or we're just watching. So I think it depends. So in fetal life, I'm just trying to prepare them for the road ahead. That's really my goal. When it's when we're talking about with an infant, it's really about preparing for next surgeries, feeling confident that they're parenting well. I was talking to a family and she's like, I just feel like the other shoe's going to drop. And I'm like, well, it probably will, but I don't mean that in a bad way. I mean, like, it's expected that you're going to go back and do more surgeries. So how do we sort of live in the moment and enjoy what you have without constantly being anxious about the next step? That means that will get there and you will need more. With younger children, we'll do some parent management training, help parents redirect behavior, use differential attention, and getting them back on track. With older kids, it's a lot more about coping. And then with the adults, it's transitioning to caring for themselves and what that looks like, or even just their own mortality, because I do think that's a big issue. I mean, they just die before we do, or they don't know how they're going to die, or it's just complicated, right? I mean, you don't know when you're going to suddenly your heart's just going to give out. So, so a lot of them live in fear around that, and sort of having a non-fulfilled life. So, yeah, I mean, I think it's just complicated. So whatever is behind door number one, we just do a variety of interventions, and hopefully people sort of see validated and heard and sort of live whatever life is available to them.
Thank you for that. And I guess, and you kind of answered it. I mean, it sounds like you kind of follow people perhaps across development, and maybe seeing them, you know, are you kind of ongoing or as needed? Is it episodic care? Kind of what does that look like?
Yeah, it's episodic, is as needed. Sometimes it takes a few times to connect with me. my availability is a challenge because there is so many patients, and there is only one of me right now. So I'm hoping that we can better serve over time, because I really think there's nothing I hate more than being like, oh, you're struggling, let me call the psychologist. That really bugs me, because it's like, oh, that really makes it look bad, right? So I love meeting people in clinic. That's why I like meeting people in Free for Life. I want you to get used to the fact that there's going to be mental health involvement. It is part of it. It is expected. It's not a big deal. We want you to have the best life possible. We have preventative cardiology now. I don't know if I mentioned it, where we're actually looking at their sort of triglycerides and hypertension and sort of providing interventions to reduce that, so then they don't develop acquired disease. So I want to be involved in all of that. If not me, the postdoc, so we can destigmatize, make it accessible, and hopefully they'll come back to us when they need help, that I'm not some kind of unknown entity, but someone who's accessible to them over time. Yeah. I'm a little bit old school. I was raised somewhere else. So, I'm one of those people that when I join a company, I stay with a company. So I tell patients that, I'm probably going to still be here in 10 years. So for better or worse, so we might as well just get to know each other.
That's great.
Any other questions I can answer? Thank you so much for having me today. It was so lovely to meet everybody. And thank you for having me.
Thank you. It's a very informative presentation. I know I learned a lot and still kind of wrapping my head around all that you do, but we really appreciate it. Thanks for coming, and thanks everyone for joining, and we will see you next month.
Thank you all. Look out for our feedback survey that will be coming soon.
Thank you.
Wow.
Bye.
Thank you. Bye.
Bye.